Hello and welcome to our public health webinar. My name is Dr. Rami Al-Rifai. I'm Associate Professor of Epidemiology at the Institute of Public Health, College of Medicine and Health Sciences, United Arab Emirates University. So the public health aspect of tobacco webinar, which is the today's webinar, is actually part of the global campaign, This is Public Health. We at the Institute of Public Health are very proud to be affiliated with the ASFER. ASFER is the Association of Schools of Public Health in the European region. We are organizing our webinars monthly with the aim of bringing keynote speakers nationally and internationally in order to highlight different important public health issues. Our webinar is accredited by the UAE University as 1 CME Category A. In this webinar, you will be able to ask questions. You can do so by clicking on the Q&A option in the middle bottom of your screen. You can submit your questions during the presentation and we will try to cover questions in the end. At the end of the webinar, we will share a link in the chat for the evaluation of the webinar. You need to fill this evaluation link to obtain your certificate. And filling this evaluation link will be highly appreciated and will provide us with more constructive feedback to improve our webinars. This webinar is recorded and the recording will be uploaded to our YouTube channel, which is the Institute of Public Health, CMHS, where you can find recordings of all webinars hosted by the Institute of Public Health. Now, allow me to introduce our keynote speaker today. For today, we are really honored that our invitation was accepted by Dr. Salma Amin. Dr. Salma is a medical doctor, worked as a community medicine physician and public health consultant at the Ministry of Health in Sudan, where she was one of the strategists and a planner for preventive medicine for the development of public health and health-related policies. She also worked as director for non-communicable diseases and a head of health promotion programs for many years. She oversaw and coordinated cancer, diabetes, and tobacco control at state and country levels. Dr. Al-Amin is also an epidemiologist and has a teaching research experiences at Tampere University in Finland, where she got her PhD. Her research focused on tobacco among young age group. She was a research field leader, supervisor of data collection, facilitator, and report writer of the Global Tobacco Surveys funded by the WHO, CDC, and Ministry of Health. Dr. Al-Amin was granted technical and scientific awards due to her outstanding accomplishments in the field of community and preventive medicine. She was awarded the CISO Prize from the University of Tampere, Finland, for showing exemplary persistence and endurance. It shows determination and bravery and reflects her work capabilities. So thank you, Dr. Amin, for joining us today. And now I'm handing over the virtual floor to you to start your webinar.
Thank you, Dr. Rami. Hi, everyone. I'm glad to be here. It is my pleasure to highlight the main issue concerning tobacco and to join you on this stage. My name is Salma, as Rami already introduced me. I graduated from Juba University and I had my first medical doctorate in community medicine from Sudan and my PhD from Finland. I'm Sudanese and currently I live in Finland. So let us start our topic.
Please, can you share your screen, please?
Yeah. The topic is about tobacco, public health aspect of tobacco. It was first written, they asked me to present something about smoking, but I'm always like looking at smoking is one of so many other kinds of type of tobacco that really need to be highlighted, and they are the same level as smoking that causes so many health problems. The aim of my presentation is, as I said before, is that to accentuate tobacco as a major health, public health problem, and to highlight its risk on health. And also, I have to concentrate more on tobacco control policies, give an example of 3 different countries, Finland, Sudan, and United States. It is very important to understand why the young people, especially kids and adolescents, to start smoking. And it is always, when we highlight this, especially those kids, highlight why they started smoking, it's always easier for the policymaker to fight tobacco from the very beginning. And the other objective or the aim is that I concentrate more on smokeless tobacco, and I'm going to take Sudanese tumbak and Swedish snus as an example of smokeless tobacco, because so many literature, a lot of literature, they were always concentrating on smoking. I just want to highlight this very important other type of tobacco products. By the end of this session, I hope that the audience and others that they can learn the knowledge, transfer this knowledge to their own community, and not only that, they have to create very effective policies and programs for the good prevention strategies of all kinds of tobacco products, and please don't concentrate on only smoking. So when we start something, I would like always to start with the history and how it started. As we all know that exactly that tobacco is not known when it started, because it was known for more than 5,000 years ago, and it was found in the Egyptians' monuments. And also, they were using it to keep it healthy, not healthy, actually, not to be not destructive, and that's when they found it, witnessed how they keep their bodies safe. People in the past, they used medicine. They used tobacco as medicine. They believe that it can cure everything, starting from bad breath, and even they use it to treat cancer. They didn't know that it can cause cancer itself. So by the 17th century, it started to spread all over, and the Americans, they were first known to use this tobacco by different kinds, snuffing and also smoking. Then the soldiers during World War II, they spread this like widely all over, and also from Europe to the colonies. Then this shisha started actually in India, and then came in the 19th century to the Arabic countries, and then now it's globally spread. In the 18th century, exactly, cancer was not, until the 18th century, cancer was not known to be one of the risk factors, the complication of using smoking. Until the 1940 and 1950, the effect of tobacco use started to be seen, especially amongst soldiers. This related to smoking, it started exactly it started to be known in 1954, when the Sergeant Leroy started to reported that cigarette is the main cause of lung cancer. The same Europe, when they know that support, they started to be aware of smoking, and they start to have their own policies. Then or snus or tumpak or smokeless tobacco became also, when it started, actually, it's very funny that it's only among the gentlemen and upper classes. They always, even they have gifts, use very precious cans and containers they between them. When we come to tobacco policies, also the history starts in area, and the good part of it, they started some countries, they started to know that there is something wrong with this tobacco. For example, in 1603, King James in England, he increased the taxes of buying cigarettes by 4,000%. That is very high. And in Turkey, Sultan Murad IV punished the soldiers because he believed that it can cause infertility and also reduce the capabilities of his soldiers. It was not proved by them, but he believed in that. Not far from there, there's like the first Romanov Fedorovich. He started also to fight against tobacco by even punish the users and sometimes kill them. In Japan, it's also they went far for execution, and the same in China. Why tobacco is a public health issue? Why all that? Why all these policies? Why all that work against it? It is the only biggest preventable public health ever known globally. It can be prevented. And also it is deadly. It causes a lot of disease. I'm not going to concentrate on this because it is known and you can find it everywhere that it causes, yes, cardiovascular diseases. It's also respiratory cancer, and almost no organ in the body is free from not being affected by using any kind of tobacco, and not only smoking. Pregnant women, stillbirths, and even underweight newborns. And the pregnant women, it's not important to be a smoker herself or using any other kind of tobacco. She can be also a victim of her husband who is a smoker. The problem also of nicotine, that one of the contents of tobacco, and that is because of addiction, especially for young who has a very soft brain and growing brain. So the nicotine is very fast, even faster than heroin, than other the other drugs. It can reach the brain within few seconds, 4 seconds. And also the victims of the second-hand smokers, as I mentioned earlier, the pregnant women and also kids are not free from that. And economically, of course, that some countries, they consume a lot of money just to treat people from the risk of their habits, like being a smoker or using any other kind of tobacco. Coming to factors influencing tobacco use, why the tobacco use is spread everywhere and it's not easy to stop using it? Because there are two factors. Actually, there are risk factors and also protective factors. How protective factors will come later to this. But the risk factors is that my concern is always about young people. Why young people? Because most of those, like starting, for example, you rarely find adults starting at the age of 30 or 35. They already became current smoker or daily smoker because they already started their smoking or using any kind of other tobacco when they were very young. The other part that is health-related knowledge and attitude and beliefs also. This we come to the this point to the norms, like some countries, they believe that that smoking or using snuff or in certain occasions, that is very important. For For example, in Sudan, tobacco is accepted socially. It's not something that bad. Maybe some people, they don't like it, but you can find it everywhere. So it's accepted. And also the knowledge about its effect is not very known. And also these factors about knowledge and income and education, it has its effects. I can't say it is risk factor, but because it has two sides. If you are less educated, if you are not, for example, if you are living in very poor neighborhoods, if you are the attitude and you are behaving differently, those are all acting as a risk factor to make you use any kind, because you don't care, you don't know actually, and or you don't care if we come to the behavior or even to the your attitude. There is also personal factor that is also included in the upper point, and that the knowledge and the self-image also. It is, for example, with e-cigarette, for example, some kids, they think that it is more prestigious, and also at university age students, they think that using it might attract other sex, like for example, boys attract girls by showing that they are using e-cigarette or any kind of other cigarettes, but sometimes it is using snuff, for example, or tobacco. Then I come to this. This is I like this figure a lot because it summarizes everything. Whatever any point in this slide, it means something. Starting from individual, that is at the bottom, that is, as I told or I said, about the knowledge and attitude of the individual who is a smoker or who is not a smoker also, and the policy acts as like covering everything, and also the community, the values and the norms. So also in America, and not only in Sudan or developing countries, also you can find that in very developed country, also in Sweden, that they use snus. It's part of the social, it's like habits for a long time. And also environmental factor, and this I'm going to talk about it in another slide. And we have the social networking. It's not only social networking by gathering in the neighborhoods, it's also we have this the internet and the social media plays a lot of role recently. There's so many studies concerning that. The environmental factor, this is the most important, especially when we are targeting, fighting or preventing tobacco use among kids and teenagers. Family comes first. Why family comes first? Because the father and mother, they are always acting as a role model for their own kids. They behave similarly, even if they are hiding themselves. Kids are, by the way, they are very smart. You can't think that they maybe whatever you do to hide something, they're always looking at you and take it as example, and then they follow your behavior. For the parents have to take care and take it serious. It's not like, okay, he's young and he cannot even see you. As young as 5, he can notice that his father is smoking, and if he cannot, he's the first one to admire, so he's following his parents, and especially mothers. And in some literature that, and I have one paper about it also, that it can be transmitted from generation to another. I have one paper that I found that the grandparents who were smokers, they affect their grandkids to smoke or to use any other kind of tobacco product. And even if they use snus, they can also be smokers or using other kind of tobacco products. Although most of those percentages of those kids or grandkids who start smoking using any kind of tobacco is mediated through the parents. So the kind of mediators. I use Finnish data where they don't have this kind of extended family as in our countries. So even the parents, the grandparents are living away, they still have the effect of the grandkids. So that means it has some genetic factors, and also there's some papers about having it like between twins, also twins study. The role of parents also can be explained by socio-psychological theories about modeling. This is big topic. I'm not going to mention it here, but it's important to look at that there is theories that explain why kids like behaving like their parents. Also neighborhood, as I told before, and also friends. And friends has a big role, especially at school, where the kids are away from the eyes of their parents, so they behave the same. I don't believe in peer pressure, but maybe indirectly in a way that if he wants to, for example, if they have a group of friends or smokers, he wants to be with them to smoke the same way. So they have some kind of pressure indirectly for him to start behaving the same. Then the schools. Why schools? It has two sides. That it is, yes, because it is established system that you can learn to smoke, and also if they have really good prevention policy, so they can stop smoking and not even start smoking. And also it is good that for the policymaker to start with schools, because where they can find kids and knowledge them, very important. It should be part of the system. And also to come to media and celebrities. I noticed that also they still smoke, especially Arabic films and series, they still smoke, and kids, they are always watching their heroes. And also in Swedish, that the hockey players, they still using snus. This is tobacco companies. Tobacco companies, they are very clever. They know what they are doing. They have power. They know, for example, when in Europe and America, I mean the developed countries, when they are fighting or they have good policies, they start to find other places for their products. And that is, for example, they always targeting poor families everywhere by giving them gifts or by very attractive advertisement. They have a powerful also influence, by the way, on the policymakers by so different means. I don't want to mention that, but people, they know. E-cigarettes, e-cigarettes started in 2006. They also start using that by attracting kids, and then after that eventually start smoking. Why I'm interested in that age of adolescents and young adults and kids? Why it is important to consider this? Why? That is because this age, they have a complex phenomenon. It is a very confusing period. They don't know what to do. They really need somebody to guide them in a way. So they always want to try something different, even if it is harmful for themselves. So it is very important to take it seriously. And also, as I mentioned before, that when they, all those now smoking, adult smoking, they start the first cigarette or the first dip or the first quit when they were young. And also they, because of their brain, that as I mentioned earlier, also nicotine, that they are really more vulnerable to be addicted more than the adult. The effective prevention is always more powerful if it started early in life, and it's always better not to stop smoking or to stop using it. It's always better not to start from the very beginning. So not even to try it. Tobacco policies. This is other part of protective factors I mentioned about the risk factor, and this is the protective factors, the tobacco policies. Tobacco policy is important, and as I mentioned before, it's always better not to concentrate on smoking, to have all as one, and for the other tobacco, it has to have I'm really concerned about the other kind of tobacco products. Why people are smoking? It's also the protective factors are expected to be protected. These policies sometimes are weak, even if in certain areas. It's also country, all the country. Maybe you find them some cities, some states, as in US. I can mention that later. But it's also sometimes they don't have this power effective policies. I'm taking Sudan and Finland as and the United States as example. From studies between Finland and Sudan, 2 studies, that they meet at one point that the use of snus is strongly influenced the use of tobacco. They have high risk of initiating smoking. If they are snus user, they're also at high risk to start smoking, both Sudanese and Finnish teenagers. There is also that when you find both studies in Sudan and Finland, that when both parents are smoking, and especially the mother, the kids are more willing to smoke. So it has nothing to do with a developed country or developing country or poor country or the continent. It's the same. So parents, number one, friends, number two, and policy that acting on those 2 parts is very important. So it is not which country, but it's everywhere. Sudan is one example. I can say, even I'm coming from there, but it's also reflecting what's going on in Africa or some other countries. We can compare to Arabic countries as well. In Africa, it is there, by the way, there are some countries. I like what is happening in Ghana, for example. They reach 88% of taxation in Ghana. Although in the west of Africa, by social norms, they don't accept smoking, especially, for example, girls. But still, Ghana, they did the big job by having this taxation raised to 88%. We have a problem of tobacco, smokeless tobacco. For example, in Darfur, the federal government depends mainly on the revenue of tobacco taxes. So that is very difficult. In short, that there is also this community or these farmers or even the federal in Darfur, they are very poor for force. It is very difficult to stop cultivating or planting or harvesting the tobacco in Darfur. And also the other problem, as I mentioned earlier, that is there is social acceptability of using tobacco. So everyone in all Sudan, they use tobacco, and also in the nearby countries, not only in Sudan. When to come to Finland, what I like in Finland, they started earlier, very early, and they have a very established and comprehensive policy, and not targeting only the adults, all the people starting from younger age. And they have a very, very optimal strategies and very ambitious steps that they are following, that they are targeting, like stopping using any kind of tobacco products by year 2030. And there I can show one diagram, and they are really going towards that goal. It is There is also mentioning Finland. I can mention something about this tobacco product directive that like cover all Europe, and that they are governing the manufacture and also the sale of tobacco. But the exception is of this law is Sweden, that they are still selling the snus publicly, and they are exception because it's, as I said, it's they are accepted by the social norms. Look at this diagram. It reflects how Finland, they are really doing well. I really like this. This is a diagram showing the progress of their policy from 2000 to 2009, 2021. If we can see how it started here, this is in 2000, the prevalence was 25%, and ending there by the prevalence of 5 within 21 years, and this is the age group between 12 to 18. So it is declining, although there is some kind of ups and downs here, but it went down, and it's going down still from that high end, and I like this. Okay, we come to United States of America. So look at this. This is if you look at this, it's very funny. The United States, for so many countries, remains an icon for so many things, and also policies. But when we look at this figure or this map, we see there is inconsistency of policies. Like, for example, in the West here, the prevalence is very low. And then we come to Kentucky and other states here on the middle or of America. There is very high prevalence, and it got up to 25% are smokers, current smoker. It's not prevalence, it is current smoking. So that means each federal has its own way of fighting tobacco use. And what made me also angry more that when California reached the lowest level of smokers in their state, they start to they stated a law to make cannabis used and publicly, and they have the sale points even near the schools. How you, as if they are closing the door of hell to open another gate of hell. How could it be that you are fighting that for so long, and then they are opening another door for something even more difficult for the teenagers to start? And I'm sure that the citizens there, they're really angry, and I don't know even why. So the lesson learned is that from this map is we need consistent policies. The consistent policy has nothing to do with the states or federal, or it should be like all over the country, and that people and also for the social norms. For example, social norms, it's difficult to change the social norms. But when we start with kids, for example, it's difficult when they are already grown and you have the social norms in your blood. But when we started with the young, and then it would be automatically after 20 years, as what that's happening in Finland, after 20 years, we have a new generation that they have their own social norms. So consistency of implementing and preventing tobacco use is very important across all countries. And this must be done for all levels. not all age, not only younger or adult or all over, and all the organizations and established systems. Yes, that doesn't mean that United States didn't do any job. It's a really great job by lowering the rate of adults. But as I mentioned, what about cannabis in California? So, for example, in 2020, like 13% of 18 and older currently smoking cigarette, and around 30 million of adults. So half of that percentages, they have smoke-related disease or illnesses in United States. So we still have a long way to reach. Sorry. Tobacco products. When we come to tobacco products, I like this picture. It shows how addicted this guy is and how smoking coming out of his nose. So that kind of addiction, that means at least he started using shisha 2 years ago before this shot was taken. So the water pipe, shisha, nargila, so different meanings, different names, I mean, with the flavored one. I'm happy that this instrument is too big to be taken by the kids to school. Otherwise, you can find it at any corner. It's widely spread in Asia, Arabic countries, even here in Europe. When Arabic came to Europe recently, they brought this shisha with them. You find them only in Arabic shops. They couldn't stop them from taking it or selling it from the shops. It's not, you cannot see them in there. They stopped using it in some cafes, but it still be used in their occasions. And not only adults, also the young ones, teenagers are using it. The problem with shisha that 3 to 4 sessions of shisha, we can count that, it's really serious. 3 to 4 sessions of shisha, I mean that each session has 14 to 90 minutes of use. Like some people, they can sit as long as 1 hour and a half. Some people, they can take it for 15 minutes. Then the session, one session, that means as if the person who was smoking cigarette, he can, as if he smoked 2 to 12 cigarettes, like in one sit. And that session, by the way, in Arabic, I guess they call it hajar. And that session, one session, exposure that long, it can be like 100 to 200 cigarettes in one sit. Just imagine someone or somebody living and like talking and taking this hajar one after another, that he ended up like smoking 100 to 200 cigarettes in one sit. We come to the new EC, or electronic cigarette. That's now its popularity growing everywhere. It's not only in Europe, but it's now started to be in the Gulf countries and also in Africa, North Africa mainly. And actually, as you know, that it's first introduced to replace to help the smokers to quit smoking. And the e-cigarettes, it's a product that it can be with nicotine or without nicotine. And as I said earlier, that the companies use this with nicotine to make it easier for the kids to start, and then they can buy their cigarettes. It has this cartridge and a tank, and the device, actually, it can be disposable also. It can be also refilled. It has, it's easy. It is very cheap when it is disposable, but you can buy one that you can refill the container each time, and then it contains something like, other than nicotine, it has a gasoline and glycol, and also some flavors in addition to that. And recently they start to add some addictive substances to it. It is easy to introduce any other substance within the same container. It uses battery, and that's why it has no smoke. And actually there is no tobacco actually. People, they think that it has tobacco, but it has no tobacco, but it has nicotine. That's one content of the tobacco and some other contents. The concentration of nicotine in this e-cigarette, the problem is that the nicotine has a slow absorption, like the absorption rate is very slow from it. So it recently they found that it can cause a lung injury. It's, only 2 years ago they found that it caused lung injury and bleeding, and it is deadly. People are still using it. Want to come to smokeless tobacco? As I said earlier, that I'm using Sudanese tobacco, and I mentioned something about having it in Darfur and how difficult to replace it, and that is also some other countries in Saudi Arabia, also Ethiopia and Chad, they are using the same, and South Egypt. So it's not easy, and the main problem of tobacco that they add alkaline solution called atron, and that make new product that is very irritable for the mucosa of the lips and causes cancer. And when that tobacco found to be highly addictive with high nicotine percentages, and it can reach up to 202 milligram in 1 gram, and that is a very high compared to snus when I come later to it. So it is socially accepted. When we come to snus in Sweden, so in smokeless tobacco there is a high percentage of nitrosamines and other carcinogens. So the Swedish, instead of stopping or fighting snus, they treated it in a way to make it less carcinogenous and also less risky for the users, because as I said, it is socially accepted and it's difficult to stop, the same as tobacco. But in Sweden, they treat it in a way. In Sudan, still we don't we are using it and even make it more carcinogenous and more. Yeah, I have a comparison. Like I hope that's clear. So in Sudan, this is the left side, and the right side is snus. So there is no curing or heating method. There is no treatment for that it's used, and they have their own way of heating methods. And here, to reduce the contamination, they are having this high temperature to kill the bacteria. There is no way for our tobacco to be reduced or treated that way. And the risk of cancer is very high in Sudanese tobacco, because the carcinogens and this nitrosamine is still there with high concentration. They lower it also in Sweden. The fermentation, we took a long time, and one friend told me that he was living nearby that area, and when he crossed, they have to cover their nose because the smell was really bad. So it's like so many miles you can have the same smell, and people, they have their villages, they live there, and they get used to this smell because of this fermentation for a long time. It's not the same as in Swedish one. And for example, when the storage time here, you see how the concentration from 32, you find it only 12, like there is almost half of it. And we call it so fun, they call it quit. That quit you can see in the picture already there. that it is like a tea bag. So they use it to reduce. So I'm coming to the end for the conclusion, and I think that it's very important policies, very important for decision makers. I can read it as it is, and health provider to create very effective policy programs and adapt prevention strategies for different kinds of tobacco products, particularly those targeting the youth and kids. More effective intervention at home, parents, siblings, friends, and also at school, and the action should be enforced, consistency, and needed to stop use from starting e-cigarette, from starting using any other kind of tobacco products, and not only concentrate on smoking, because it is easy to hide the dip and easy to hide the quid inside the mouth, and so the parents should take care of that, and especially when the child asking for more money and then disappearing in a way that is not clear or not explained. So, and also to watch their friends. Please, consistency and sustainability of the program, and the lesson learned are that we need consistent policy. Thank you.
Thank you, Dr. Salma, for the nice presentation. And let me take it from where did you end, which is that we really need consistent policies in order to control the tobacco use. So tobacco smoking and use is a global public health issue. And as you mentioned, whenever there is a policy, new policies or strategies to control the tobacco company or companies are intelligent enough to come up with the new strategies to recruit young generations in the nicotine use. So recently we started to see e-cigarettes, vaping, and so on and so on. So yeah, again, thank you so much for the nice presentation. So I would like to ask the audience, and actually because of this is a very important public health issue, I'm very happy to see participants from different regions around the world. So thank you for joining us today. And if you have any question or comment, please drop it in the chat box so I can read your comment. In the meanwhile, I think we already have a couple of questions. So Dr. Salma, we have a question about, in your presentation, you mentioned different type of tobacco, for example, the snus, tumbac, and other chewed forms of tobacco. So could you please explain more about the content? Are the content same? Are the addiction levels same, and so on and so on? So the audience are interested to know more about those different types of tobacco.
Yeah. For example, as I mentioned earlier, that they are different also from different countries. For example, in India, they have their own like chewing tobacco, and also in Yemen they have this cut, although it can be considered something else. But the absorption is important. For example, in the Sudanese tumbac, they have this atron that it make it absorb easily. So but this absorption reduced in this snus, in the Swedish one.
Mm-hmm.
When it comes to cigarette, for example, it is different because it comes to the lung, the smoke comes to the lungs, and then the absorption from the lung is also faster by the small vessels, that it goes faster to the brain. But for example, the absorption from the mucous membrane in the tongue concerning the chewing or the other like dipping, it's also faster because there is very the mouth is very vascular, so it is easy to be absorbed. They are different, but when it comes to nicotine, almost the same, because nicotine is very dangerous because it finds its way. I have a diagram. I wish I brought it there because it shows how it crosses the blood vessels and taken by other enzymes, because other enzymes like blind to consider it as one part of the body, so it goes faster to the brain.
Okay. Yep. So yeah, we have one question from Connie. Please excuse me if I'm not pronouncing your name correctly. So the question is
Dr. Rami,
about,
if I just add, I allowed Ms. Coney or Dr. Coney to unmute her mic if she wants to speak.
okay, so yeah, that's great. Yeah, so can you unmute yourself or your mic and speak?
Thank you. Thank you, Dr. Salma, for a wonderful presentation. I know you've done a lot of work on schools and policies and their effectiveness or implementation. Could you comment on that for us, please?
Yeah, for sure. Yeah, in Sudan and also here in Finland, we were collecting data concern or data at some countries. We're collecting data about kids or teenagers, and we analyze that, and we have the reports also published that we have the prevalence was very high concerning smoking, that unexpectedly we didn't know that the kids were smoking, because you can't see that like openly on the streets, and also they were using this snuff. But when we come to, for example, school, like higher school at the university level, we found the smoking like higher percentage than tobacco use. Maybe because they are at the university level, they want to be more prestigious and good looking, as I said earlier. But they are still using tobacco and smoking also. And we found that also residential smoking has effect on students. That it's not only because they are at the established school or college that they are smoking because of the friends, also back home. So that it reflects, even if they are grown and cross their 20s or 18, the effect of the parents and the neighborhood is still there. So the school has a role with their policies, and the neighborhood has a role, and also residential smoking in their home also act on that especially in Sudan. When it comes to Finland, because the data also, it's not like they are not collecting data from schools, but they are collecting data by age. That is because they have very established registry, I mean. So, but the age is like goes with basic schools and high schools, that between 12 to 18. There is no difference between different communities, either in Sudan, in Finland, although they are different in policies, they are different also in their culture, they are different in their social norms, but also the same, that school has a role in a way that, for example, we found that with the students with low school performers, they are highly like smokers than compared to the others, the same in Sudan. So also the teenagers, the age, for example, females at 1 year or 2, we found that the girls and boys are the same level, and what at one point the girls start to smoke even more than the boys, and mostly they are affected by their own mothers. So it is kind of a mesh. Everything is acting on those, like at school or out school, and it's like that. So I wish that it's that.
Thank you. Yeah, thank you, Dr. Salma. We have a raised hand by Mr. Marco Cornito. So you can unmute your mic and start speaking, please. Mr. Marco or Mrs. Marco, I'm not sure. Okay, so we cannot hear you, Mr. Marco. So we have another question in the chat box, which is Niveen Rauda asking, how can we relate smoking to students' well-being?
How can we
relate smoking to students' well-being?
Well-being of the students. How
Yes.
can we reflect that?
Exactly.
Yeah, I think this is a role of the school, the role of the teachers. For example, also one of my studies, I found that the teacher also acting as a role model, and when the teacher smokes, the kids are smoking as well. and they can see the teacher even smoking school premises, even around the school. Even if the teacher, for example, starts smoking outside, he can also be seen. About the well-being, the well-being of the students is not only smoking, as there are so many other like very important points concerning their health. But I'm always like wishing that if they include tobacco policies, or tobacco is one of the curriculum in the school, in their well-being, to be part of their studies, at least for the knowledge, then the behavior is a role of all those factors that I already talked about. So they are all acting together for the well-being of the kids in their schools.
Mhm. Yeah, thank you. I think there's another very interesting question by Hiba Adam. She asked about, could genetics used to predict the risk of future smoking? And if so, what behavioral models could be employed to intervene?
Good.
Genetics, like if they
Genetics.
yes, to predict future.
Yeah, they found that there is certain, it's not like known which gene, but they found that, for example, there are some studies about twins, and also some studies between siblings. They found that the twins, even if they are separated, once one started, the other also like is also behaving the same. And it is also a high percentage that is like really there is something behind the vulnerability of starting smoking, or not only smoking, is also using drugs or even became alcoholic. So the certain genes. And also I have that study that although in Finland they don't have this kind of extended family, still the grandparents affect the grandkids to smoke. If the grandparents is smoker, the grandkids is also smoker, although it's, as I said, it's mediated through their own parents, either the mother or the father.
Yeah, yeah. So my understanding, Dr. Salma, so there are studies published about, or there are studies related to this, like specific genes that make the people at risk of becoming smoker in the future.
Exactly.
This very interesting.
Yeah.
Yeah, thank you so much. I'm looking at the. I'm not sure about Professor Munir asking about cigarettes and ADHD. I don't know what's this abbreviation. Is there a robust relationship between like ADHD and smoking?
Actually, every move concerning smoking, it's like training to use any kind of other drugs, including this one, other cannabis or heroin, or it's like practicing. So expecting that the smokers are more vulnerable also to use this all other kinds of medication or drugs, as we can call, not medication, actually it's drugs. And the same was, and I was angry with California, for example, when I mentioned that how could it be they close the door of a smoke, and they have very good progress in fighting or preventing tobacco use, and then they are opening this cannabis for use and publicly sell near the schools. It is bit something that not easy to understand.
Yeah.
I wish he could the answer for that one. Yeah.
Yeah, so actually there are so many comments in the chat box, Dr. Salma, appreciating your representation and the content of your presentation. So we have, because of the time limitation, we can take one more question from the chat box, which is asking about the prevalence of smoking in relation to gender and age in Sudan specifically and Arab countries. I guess the question also follows by saying, I guess more ladies and more younger ages are shown in many studies. Do you agree or?
Yeah, there are so many studies, yes, conducted in Sudan. For example, my studies was the whole Sudan together, that a long time ago when we have this north and the south like together. But recently it ranges, for example, based on the age. For example, I had this 19% of school going kids are smokers. And also we have lower percentages and of using tobacco, like above 8% in one study. And the funny part also about this, the shisha users, it starts to be used like between girls, and actually it's not like using it for anything else other than some of them, they want to put on weight, and they believe that shisha can let them gain weight and eat more. And actually this information is everywhere in the salons, and even they are using it in their own homes to use shisha because to put on weight.
Yeah, also, if you allow me to add, because the recent or other forms of tobacco other than cigarettes, which is more socially acceptable, specifically for the females. So shisha, socially acceptable, culturally acceptable to see a female smoking shisha more than seeing a female smoking cigarettes and so on. So,
yeah, that's funny. Yeah.
So I think for the interest of time, we are exactly at the end of this allocated the time allocated for this webinar. So Dr. Salma, she was very generous and in terms of the content of the slide presentation, and she's happy to communicate with you further. So her email is presented in this slide. So she is happy to receive any email or comment from your side. Please feel free to communicate with Dr. Salma. So by the end of this webinar, so Dr. Salma, again, thank you so much for kind acceptance to share your slides and to share your presentation today. So on behalf of the Institute of Public Health and all of the audience who joined us today, I would like again to thank you, Dr. Salma, for accepting our invitation and for an excellent and very thought-provoking presentation. Thank you also for all of you who participated today. If you would like to receive the certificate of attendance, please fill the link of the survey in the chat box. I want to thank also all of those who made this webinar possible, management of our college and UAE University, who gave us a green light and supported organization of the webinar, the organizational and technical team, Professor Michael Grivna, Mr. Sajid, Mr. Ismail, Dr. Rifat, Ms. Bayan, and Mr. Amino, and the webinar coordinator, Dr. Asar Talal. So the next webinar to be organized by the IBH will be held on January 2023, and we will announce the details soon. Please follow us or follow the Institute of Public Health on social media channels. We have account on LinkedIn, Twitter, Instagram, and Facebook at the UAE-IBH to find more details. You can find the recordings of all those already held webinars, delivered and held webinars hosted by the IBH at our YouTube channel, which is the Institute of Public Health-CMHS. We look forward to seeing you all in the future webinars. Thank you so much for joining us tonight. Thank you, Dr. Salma, again. And
Thank you.
I would like to close the session. Thank you so much.
Thank you. Bye.
Bye-bye.
Bye.